Assalamu alaikum, bismillah ar-Rahman ar-Rahim. I'm Professor Numan Nafie, and the objective of this lecture include some definition neonatology and to know what is low birth weight neonates, to know the all details about preterm babies, their complications, early and late complications, and we start with the first complication, respiratory distress syndrome, and the second complication. These are acute complications. So I have to take a quiz. Pregnant woman in her first trimester came for regular antenatal care visit. One of the following cannot be used by the obstetrician during this visit to assess the gestational age. Of the following cannot be used by the obstetrician during this visit to assess the gestational age. The data of last menstrual period, the expected delivery date, quickening, first reported fetal heart sound, abdominal ultrasound examination. The second quiz is a 750-gram female experienced respiratory distress after preterm delivery at 27 weeks gestation. Pregnancy was uncomplicated, but labor was abrupt, and therefore the mother did not receive a steroid or penicillin therapy before delivery. The baby required intubation and mechanical ventilation with 100% O2. The possible causes of respiratory distress include all the following except spontaneous pneumothorax, transient tachypnea of newborn, lobar emphysema, group B streptococcal infection, and respiratory distress syndrome. The neonatal period is the first 28 days of life or the first week of life, either early, which is the first week of life, or late, from 8 to 28 days of life. Some definitions, we also have the perinatal mortality rate is the number of deaths the number of deaths from 20 weeks of gestation till birth, plus the death in the first week of life per 1,000 total births. While neonatal mortality rate is the number of deaths during of a newborn during the first 28 days of life per 1,000 live birth. How we assess the obstetrician will assess the gestational age prenatally by last menstrual period, expected delivery date, quickening, a fetal heart sound, and by ultrasound examination before 20 weeks of gestation. Postnatal gestational age is assessed by expanded Ballard scoring system, and after completing the scoring by Ballard scoring, we will classify the baby either he's a term baby or preterm or post-term. And then we put the gestational age against the weight, length, OFC, and we'll classify them as either small for gestational age or appropriate for gestational age or large for gestational age babies. Full-term neonates normally have the following. They have a body weight of 2.5 to 4 kg, length of 50 centimeter, OFC of 35 centimeter, hemoglobin of 14 to 22 gram per deciliter, white BC count of 5,000 to 20,000 per cubic millimeter, blood pressure of 80 over 50 millimeter mercury, respiratory rate of 40 to 60 breath per minute, pulse rate 120 to 160 beat per minute during awake, and it might be low, 70 to 80 while sleepy. Urine should be passed within 24 hours. Meconium should be passed within 24 hours, maximum 48 hours. If more, we should think of other conditions like perforated anus or Hirschsprung disease. The new Ballard scoring system, as we said, include neuromuscular maturity, 6 signs or scores, and physical maturity, 6 also. And we use both of these 12 scores to give total score. The total score of maturity rating start from -10, which is equivalent to 20-week gestation, to 50 maximum, which represent 44 weeks gestation. And this is example of extremely preterm baby who is low birth weight and mechanical ventilation through endotracheal tube. So preterm baby, as we said, and we put the we take the gestational age from the Ballard scoring system, and then we put the gestational age against the weight, the length, and the OFC, and then we decide on this table whether classify him whether he's large for gestational age or appropriate for gestational age or small for gestational age. And this is a picture of preterm baby, the smallest one, and then in the middle, small for gestational age, and the larger is the large for gestational age baby. And these are also two large for gestational age babies, and in between there's premature baby who is 24 weeks gestation and just 400 grams. You look to his color, it is dark, deep red color, transparent skin. This is features of preterm babies. Preterm infants on CPAP and IV cannula on right forearm, and there is sphygmomanometer cuff on the left arm. This is a low birth weight, previously called light for death baby. He's less than 2.5 kg, and when you put him on a growth chart, his body weight fall below 10th centile. He had a head which appeared disproportionately large for his thin-waisted body, and this results from placental insufficiency leading to intrauterine growth retardation late in pregnancy. They may also have hypoglycemia as complication. Postpartum babies, they are those babies who are delivered after 42 weeks of gestation, and the infant has characteristically dry, peeling skin. Low birth weight neonates, they are neonates whose birth weight less than 2.5 kg. They could be either preterm or small for gestational age or both. Preterm babies are a neonate who was born before 37 weeks completed. The causes behind premature delivery include maternal causes, placental causes, uterine causes, fetal causes, and other causes, miscellaneous. So these are details of the causes of premature delivery, including maternal causes like maternal age, grand parity, smoking, poor housing, short stature, alcohol consumption, and then placental causes, placenta previa, abruptio placentae, uterine causes, bicornuate uterus, cervical incompetence, fetal causes including fetal distress, multiple gestation, erythroblastosis fetalis, congenital anomalies, then other miscellaneous causes including premature rupture of membrane, polyhydramnios, iatrogenic causes. What are the clinical features of preterm babies? They have larger head size compared with the body size. They have pink skin color or deep dark red color and with a thin transparent skin. They sleep almost all the time. Normally, even a term baby can sleep up to 15 hours per 24 hours. Preterm babies might sleep more. They are hypotonic, and when there is a full extension of the legs and arms, we call it frog-like position. No palpable or small little breast tissue, shapeless soft ears. They have undescended testes in the males and widely separated labia in the female, with the labia minora not covered by labia majora. They have weak cry, suckling, swallowing, coordination, and cough reflexes predispose them to aspiration pneumonia. They have little subcutaneous tissue, and this might predispose them to hypothermia. The body is covered with black, soft, brittle hair all over the back shoulder called lanugo hair. What are the complications of being a premature baby? This include birth asphyxia and the need for resuscitation called perinatal depression due to immature respiratory center in the brain, flared chest wall, and this deficiency of surfactant. Thermal instability, whether hypothermia or hyperthermia, can occur as a complication of prematurity. Hypothermia due to immature heat regulating center in the brain, poor motility, little subcutaneous fat, large surface area of the body and the skin compared with his body weight. They have weak cough, suckling, swallowing, and coordination, and this predisposes them to respiration pneumonia. They have many respiratory problems, including apnea, respiratory distress syndrome, pneumothorax, pneumomediastinum, pneumoperitoneum, and jaundice and liver immaturity. Because of liver immaturity, the baby might develop also bleeding because of inadequate or low level of coagulation factors, which is synthesized by the liver. And also they are liable to have hypoproteinemia because the albumin is also synthesized in the liver, and after hypoproteinemia they will have edema. They are predisposed to many metabolic complications, including hypoglycemia, hypocalcemia, hypomagnesemia, metabolic acidosis. Cardiovascular diseases or complications can occur, including hypotension, vasodilatation, low or poor myocardial contractility. This leads to hypotension and even heart failure, especially those with RDS. They are liable to have many CNS complications, including the apnea, convulsion or seizure, intraventricular hemorrhage, preventricular leukomalacia. The other problems, including GIT problems, they have poor tolerance to milk, especially the standard formula, and especially the lipid part of it. They can have vomiting, abdominal distension, paralytic ileus, or even necrotizing enterocolitis as complication of prematurity, which is dangerous and associated with high mortality and morbidity. Increased susceptible to infection because of impaired cell-mediated immunity and low immunoglobulin level. And these are immunoglobulins come from the mother through placenta in the last trimester. Hematological, including anemia, which could be early or late, and jaundice. Ophthalmological complication, the most important of which is the retinopathy of prematurity, and this can lead to visual impairment if not diagnosed and treated at appropriate time, and even can lead to blindness. Surgical problems, especially inguinal hernia, which can strangulate if not operated upon. So we need to operate as early as possible. Renal problems, including decreased glomerular filtration rate, hypokalemia, hyponatremia, hypernatremia, metabolic acidosis, poor tolerance to high sodium and solute and fluid overload. They have deficiency, they are liable to have deficiency of iron, vitamin D, folic acid, phosphate, and other minerals and vitamins. This is a newborn baby who is preterm and developed jaundice that require phototherapy. The outlines of management of preterm neonates: immediate postnatal management should be in tertiary hospital or a hospital that is equipped with well equipped with machines that is needed for preterm babies, like ventilators, surfactants, and other advanced care. And this hospital is also having well-trained doctors and nurses. So every delivery before 28 weeks should be, the mother should be transferred to tertiary hospital before delivery, because the mother and baby require more intensive care. These neonatal management, including thermal regulation, by incubator care, respiratory support, like giving oxygen by nasal cannula or by continuous positive air pressure, and even assisted ventilation by mechanical ventilator. Circulatory support, they might provide fluid, blood, plasma, albumin infusion, and different types of fluids, including normal saline, IV fluids, dextrose, and others. Monitoring heart rate, respiratory rate, pulse rate, temperature, the use of pulse oximeter, the use of transcutaneous monitoring, the use of blood gas analysis, especially in cases of severe preterm with severe RDS on mechanical ventilator, chest X-ray needed to diagnose pneumonia, RDS, or to check the tip of endotracheal tube in the trachea, or umbilical vein or umbilical artery catheter. Metabolic disturbances also need to be monitored and diagnosed and treated early, especially the hypoglycemia. And in a preterm baby, we usually start fluid of 80 to 100 ml per kg per 24 hours in the first day, then increase it up to fifth day by 150 to 180 ml per kg per day. We start with the glucose, dextrose 5 or 10%, then in the second or third day, we start with 1/5 glucose saline. Minimal handling, because excessive handling of preterm baby might lead to apnea, desaturation, arrest. Nutrition, we usually start with parenteral nutrition, whether it is partial or total, and later we start with enteral feed by NG tube feeding and then direct oral feed. Also, the preterm baby requires supplementation of calcium, phosphate, vitamin D, iron, folic acid. Erythropoietin plus iron is needed to decrease the need for frequent transfusion. Delayed cord clamping for at least 1 minute have been shown to be effective and for term and preterm babies to increase blood volume to prevent the likelihood of development of later anemia. And hyperbilirubinemia might be severe, and the TSB is high, that require phototherapy and even exchange transfusion. Infections need to be prevented and treated. Prevention by appropriate hand washing and the use of gel, and prevent overcrowding of the neonatal care unit by the patients and by the staff. And try to isolate infected persons, neonates, like those with septicemia and meningitis, from other neonates. And then treatment should be according to the, after taking the appropriate infection screen, like blood culture, CRP, complete blood picture. We will give an empiric treatment that cover both gram-positive and gram-negative organisms until the result of culture and sensitivity appear, then we can change accordingly. Immunization of preterm baby is the same as term baby, except that hepatitis B vaccine usually given after the baby when the baby's birth weight the baby's weight become more than 2 kg. And this is immunization of all preterm babies. This is for reading, not for examination. This is by the American Academy of Pediatrics. Prognosis of those infants with only moderate problem adjusting to extrauterine life is good. The risk of mortality and morbidity is decreased with increasing age. Severe impairment occur in a small population. And recently, infants born before 28 weeks had bad prognosis, but now with intensive care, including artificial ventilation, use of CPAP, IV nutrition, like TPN, more and more preterm babies are surviving. For long-term sequelae, 10 to 15% of those less than 1,500 grams are found to have some major handicap, including cerebral palsy, mental retardation, other developmental delay, blindness, and deafness. We will start to talk in detail about complications of prematurity. We have the acute complications that occur while the patient is still in the hospital, including respiratory distress syndrome, patent ductus arteriosus, intraventricular hemorrhage, jaundice, and an early anemia prematurity. The late complications might occur while the patient is in the hospital or after discharge home, including retinopathy prematurity, bronchopulmonary dysplasia, late anemia prematurity, rickets, and different degrees of brain injuries. So the first early complication includes respiratory distress syndrome, or previously called hyaline membrane disease. It is deficiency of pulmonary surfactant, which is a mixture of phospholipid and protein. It will decrease the surface tension and prevent alveolar collapse. The surfactant is produced by type 2 pneumocyte in increasing quantities from 24 to 25 weeks of gestation onward, reaching normal concentration at 34 weeks. What are the risk factors which increase the risk of development of RDS, including prematurity, male sex, familial predisposition, elective cesarean section, perinatal asphyxia, chorioamnionitis, multiple gestation, and maternal diabetes? There are also factors which decrease likelihood of development of RDS, including chronic intrauterine stress, prolonged rupture of membranes, maternal hypertension, narcotic or cocaine use, small for gestational age, the use of corticosteroid, thyroid hormone, and tocolytic agents. Clinical features of RDS: preterm babies with RDS, the RDS tend to be more common in males than in female, more in preterm than in term babies. They are rare in term babies, except in infant or diabetic mother, hypoxia, acidosis, hypothermia. It worsens in the first few hours of life and then progress over 48 to 96 hours and subsequently improve. They present immediately after delivery with tachypnea, expiratory grunting, chest recession, intercostal, subcostal recession, chest indrawing, and cyanosis. And the sign of improvement of the RDS is the brisk diuresis. Death is rare in the first day when it occurs usually from the second to seventh day due to pulmonary hemorrhage, intraventricular hemorrhage, pneumothorax, and other air leak syndromes. But how we diagnose RDS? Diagnosed by clinical course, we already mentioned in the previous slide. Chest X-ray will show ground glass appearance or white out lung, and later we might see air bronchogram. Blood gas usually show an increased PaCO2, decreased PaO2 and pH. Other lab investigations might be needed, like blood culture, CRP, complete picture, blood sugar, and echocardiography to exclude congenital heart disease. By chest X-ray, a patient with respiratory distress will have ground glass appearance or white out lung with air bronchogram. In the upper chest X-ray, we are seeing the lungs are white and the boundaries of the heart are difficult to differentiate. And in the lower chest X-ray, we are seeing the air bronchogram is also clear. This patient also had PDA with RDS. The differential diagnosis of respiratory distress syndrome include transient tachypnea of newborn, which need to be differentiated from RDS by being, the TTN is of shorter duration and milder clinical course than RDS, and require low oxygen and respiratory support. Other differential diagnosis is group B streptococcal infection, and sometimes difficult to differentiate between RDS and group B streptococcal infection. For this reason, any patient with RDS usually given antibiotics. Other differential diagnosis includes cyanotic congenital heart disease, and need to do echocardiography, aspiration syndrome by maternal blood or meconium, or later milk can cause aspiration. Primary pulmonary hypertension of newborn, spontaneous pneumothorax, diaphragmatic hernia are causes of respiratory distress. And diaphragmatic hernia, the patient usually present with the scaphoid abdomen, and if you auscultate over his precordium. You find the apex beat on the right side. This is in this condition you have to exclude diaphragmatic hernia. Pleural effusion, lobar emphysema, and congenital anomalies of the lungs are also another differential diagnosis. The prevention of respiratory distress syndrome initially by the obstetrician and then by the pediatrician. The obstetrician can prevent RDS by preventing premature delivery, by appropriate management of high-risk pregnancies, by prenatal diagnosis of high-risk neonates, by avoiding unnecessary or poor timed cesarean section. And now you are seeing a lot of cases of cesarean section with unclear or not, the indication for cesarean section is not clear and loose, and a lot of preterm babies come because of wrong decision regarding cesarean section. Also, the obstetrician can prevent premature delivery by antenatal steroid given to the mother as 2 doses of betamethasone, 12 milligram intramuscularly at 24 hours interval, administered 48 hours before premature delivery of fetuses between 24 and 34 weeks of gestation. And then the pediatrician or neonatologist can prevent RDS or decrease its severity by giving prophylactic surfactant immediately after delivery within 15 minutes up to 1 hour. And then now the most recent evidence-based medicine to prevent RDS is the immediate delivery room initiation of CPAP with early rescue surfactant administration. And what we mean by early rescue, we give the surfactant within 2 hours. I mean, after confirming diagnosis of RDS, after confirming the diagnosis of RDS by chest clinical course chest X-ray and blood gases. Treatment of RDS includes supportive and specific. The supportive, these are the outline of management of preterm baby in general, including fluid and nutrition, gentle minimal handling, circulatory monitoring, temperature control by incubator care, and we have to provide warm humidified oxygen because cold air, warm air, dry air are irritant to the airway passages. So preferably warm humidified oxygen. And both the CPAP and the ventilator, they usually warm, they have a humidifier as part of the machine. Sometimes the use of nasal cannula oxygen is not enough. We need to put the patient on CPAP, and has been shown that CPAP decreases the need for mechanical ventilation and surfactant administration if the CPAP started early in the delivery room. And you know that surfactant is very expensive, and if we can use CPAP early in the delivery room, we might elevate the need of surfactant administration and even mechanical ventilation. So sometimes the patient with severe RDS and on CPAP might fail CPAP, and the patient continue to have severe RDS, frequent apneas, desaturations, and severe work of breath. In such case, we put the patient on mechanical ventilator. A specific treatment by administration of exogenous surfactant through endotracheal tube, we give it as early rescue surfactant administration after confirmation of diagnosis of RDS by clinical course chest X-ray and blood gases. Sometimes we need a second dose, and rarely we need a third dose of surfactant. Complications of RDS and its intensive care: the endotracheal tube complication, umbilical artery and vein catheter complication, like introducing the catheter too far or too close, or perforation care, or thrombosis, or thrombophlebitis. Extra pulmonary extravasation of air like pneumothorax, pneumomediastinum, pneumoperitoneum, pulmonary interstitial emphysema. Other complication of being premature and RDS, they can develop PDA and apnea and bradycardia and chronic lung disease called bronchopulmonary dysplasia. Prognosis of RDS: the prenatal diagnosis of high-risk pregnancies and neonates, improvement in the intensive care, antenatal steroid, postnatal surfactant administration, and improved modes of ventilation. All above measures reduce the mortality to less than 10%. The mortality rate is inversely related to gestational age. The outlook is better in newborn more than 1,500 grams. 80% of those less than 1,500 grams have non-neurologic or mental sequelae. 80 to 90% of those surviving RDS and its care are normal, and the long-term prognosis for normal pulmonary function in most infants surviving RDS is excellent. And this is a chest X-ray and a patient with the preterm and RDS. He got pneumopericardium as complication. And this is a chest X-ray when there's left pneumothorax in infants. Left pneumothorax in infants on a ventilator on 2 days of life. And this is bilateral interstitial emphysema, also complication. This is abdominal X-ray in a patient with pneumoperitoneum. There is air in the peritoneal cavity. And this is also a case of necrotizing tracheitis as complication of premature and RDS. They have free air and gas in the peritoneal cavity called it's called pneumatosis intestinalis. And in this X-ray, also necrotizing enterocolitis with intramural gas here, and here is very clear. And there is a portal vein gas, which is late sign of necrotizing enterocolitis. And this is a chest X-ray. We saw it as a case of RDS and patent ductus arteriosus, and the air bronchogram is very clear here. And this is X-ray, show how they insert the umbilical vein catheter, and then it reach above the diaphragm, and then the tip of the nasogastric tube in the stomach. And this is also the umbilical artery catheter, high type, usually from between T6 and T9. While low umbilical artery catheter, they are usually between L3 to L5. The second complication of prematurity, acute complication, is patent ductus arteriosus. Definition is failure of ductus arteriosus to close in the first few days of life or reopening after functional closure. The incidence is up to 60% in preterm, less than 1,500 grams, and higher in 1,000 grams, up to 70%. Risk factors: the PDA in preterm infant is mostly due to immaturity and hypoxia, while a term baby with PDA, usually it is a congenital heart disease due to structural defect in the wall of the ductus arteriosus, and they require operation later on. While a patient with preterm babies with PDA, they can close spontaneously or sometimes with the drugs and rarely require operation. Clinical features: the patient with a preterm baby who got he was stable on CPAP or ventilator, then he started to deteriorate and going more tachypnea, more respiratory stress, and when you auscultate his chest, you find continuous machinery murmur in the left infrasternal position or in the second intercostal space, and there might be mid-diastolic rumbling, and there might be wide pulse pressure, bounding pulse, which can be felt even in the palms. ECG might be normal in small PDA, could be, while in moderate PDA there might be left ventricular hypertrophy, and in very large PDA there will be biventricular hypertrophy. Chest X-ray will show cardiomegaly and increased infiltration on the lungs, as we see in the previous chest X-ray. Echocardiograph will diagnose the PDA. Management depend on the size of the PDA, whether it is hemodynamically unstable. Then the patient need fluid restriction and diuretic, and we can give indomethacin IV infusion. It's not available in Iraq. We use oral ibuprofen, and oral ibuprofen have been used in many countries and still effective, and sometimes it is more effective. I mean, it has a less side effect than indomethacin, especially regarding the renal impairment and the GIT bleeding. Rarely we need to do surgical closure of or ligation of the ductus. And this is chest X-ray. When a patient who has RDS, they have ground glass appearance and air bronchogram here, features of PDA and RDS and PDA. And thank you very much.